Good morning everyone. Today we are going to conduct a session on aminoglycosides antibiotic. It is a part of a series of videos of antibiotics. So let's start the pharmacology of aminoglycosides. Today we will learn about the introduction, common properties of aminoglycosides, the classification, mechanism of action, dosing, adverse effects of aminoglycosides, therapeutic uses, and we will also discuss some aminoglycosides. Introduction. Aminoglycosides are a group of natural and semi-synthetic antibiotics having polybasic amino groups linked glycosidically to two or more amino sugar residues. Unlike penicillin, which was a chance discovery, aminoglycosides are products of deliberate search for drugs effective against gram-negative bacteria. Streptomycin was the first member of aminoglycosides, which was discovered in 1944 by Waxman and his colleagues. It assumed great importance because it was active against tubercle bacilli. Others were produced later, and now aminoglycosides are a sizable family. All aminoglycosides are produced by soil actinomycetes and have many common properties, which we will discuss now. Common properties of aminoglycosides. Aminoglycosides contain two or more amino sugars attached by glycosidic linkage to hexose ring. They are highly polar compounds, hence poorly absorbed from the GI tract. They are administered by parental route for systemic effect. They are mainly distributed into extracellular fluid and are poorly penetrate into the CSF. They are not metabolized in the body and are excreted unchanged in urine by glomerular filtration. They have bactericidal action against gram-negative aerobes and are more active at alkaline pH. They cause ototoxicity and nephrotoxicity, and they also exhibit partial cross-resistance among them. Transporter of aminoglycosides into the bacterial cell requires oxygen, so hence anaerobes are resistant to aminoglycosides. Systemic aminoglycosides include streptomycin, amikacin, gentamicin, sisomycin, kanamycin, netilmycin, tobramycin, and paromomycin. Topical aminoglycosides include neomycin and fremicetin. Now let's discuss the mechanism of action of aminoglycosides. The aminoglycosides are bactericidal antibiotics, all having the same general pattern of action, which may be described into two main steps. First, transport of the aminoglycoside through the bacterial cell wall and cytoplasmic membrane, and second, binding to ribosomes resulting in inhibition of protein synthesis. Transport of aminoglycosides into the bacterial cell is a multi-step process. They diffuse across the outer coat of gram-negative bacteria through porine channels. Entry from the periplasmic space across the cytoplasmic membrane is carrier-mediated, which is linked to the electron transport chain. Thus, penetration is dependent upon maintenance of a polarized membrane and on oxygen-dependent active processes. These processes are inactivated under anaerobic conditions. Therefore, anaerobes are not sensitive and facultative anaerobes are more resistant when oxygen supply is deficit. Penetration is favored by high pH. Aminoglycosides are 20 times more active in alkaline than in acidic medium. Once inside the bacterial cell, streptomycin binds to 30S ribosomes, but other aminoglycosides bind to additional sites on 50S subunit, as well as to 30S and 50S interface. They freeze initiation of protein synthesis, prevent polysome formation, and promote their disaggregation to non-functional monosomes so that only one ribosome is attached to each strand of mRNA. Binding to aminoglycoside to 30S and 50S junction causes distortion of mRNA codon recognition, resulting in misreading of the code. One or more wrong amino acids are entered in the peptide chain, or peptides of abnormal lengths are produced. Different aminoglycosides cause misreading at different levels depending on their selective affinity for specific ribosomal proteins. The action of these drugs appear to be based on secondary changes in the integrity of bacterial cell membrane because other antibiotics which inhibit protein synthesis are only static. After exposure to aminoglycosides, sensitive bacteria become more permeable, ions, amino acids, and even protein leak out, followed by cell death. This probably results from incorporation of the defective proteins into the cell membrane. Now let's discuss the mechanisms of bacterial resistance. Bacterial resistance to aminoglycosides is due to the inactivation of the drug by bacterial enzymes, decreased entry of drug into bacterial cell, and decreased affinity of the drug for the ribosomes. Aminoglycosides exhibit two effects, a concentration dependent killing effect and a post antibiotic effect. The concentration dependent killing effect is higher the plasma concentration, more of the bacteria are killed rapidly. And post antibiotic effect means bactericidal effect is present even when serum concentration falls below the minimum inhibitory concentration. Therefore, once daily dosing regimen is effective. Two dosing regimen are there for aminoglycosides. First is once daily dosing regimen and multiple daily dosing regimen. Once daily dosing regimen, the total daily dose is given as a single injection. It is preferred because it is as effective as multiple dose regimen. Higher peak concentration is achieved following single dose. It is safer than multiple dose regimen. The plasma through concentration of aminoglycosides remain below threshold levels for toxicity for a long period of time, and it is also convenient. Multiple daily dose regimen, the total daily dose is administered in 2 or 3 equally divided doses. Once daily dose regimen is not preferred in bacterial endocarditis, children, and patients with renal impairment. Dose adjustment for aminoglycosides is done according to body weight and creatinine clearance. Okay, so now let's see the adverse effects of aminoglycosides. So the first adverse effect is ototoxicity. Vestibular and cochlear dysfunction can occur due to 8 cranial nerve damage. Aminoglycosides get concentrated in the perilymph and endolymph of the inner ear, which can lead to progressive damage of vestibular and cochlear hair cells. Streptomycin and gentamicin mainly affect vestibular function. Vestibular dysfunction causes intense headache, dizziness, nausea, vomiting, vertigo, and ataxia. Amikacin and kanamycin affect auditory function, causing more cochlear damage. The manifestation of cochlear damage are tinnitus and deafness. The important risk factors for ototoxicity are the following: elderly patients, repeated courses of aminoglycosides, persistently increased concentration of the drug in plasma, patient with pre-existing auditory impairment, concurrent use of other ototoxic drugs such as vancomycin, minocycline, and loop diuretics. Second adverse drug effect is nephrotoxicity. Aminoglycosides get concentrated in the renal cortex and produce nephrotoxicity, which is usually reversible on discontinuation of the drug. The incidence of nephrotoxicity is highest with neomycin and least with streptomycin. There is decrease in urinary concentration capacity, albuminuria, etc. The risk factors for nephrotoxicity are elderly patient, pre-existing renal disease, and concurrent use of other nephrotoxic drugs such as vancomycin, cisplatin, and cyclosporine. Aminoglycosides also produce neuromuscular blocking effect. Apnea and muscular paralysis have been reported. It may be reversed by administration of calcium salt. Aminoglycosides inhibit release of acetylcholine from motor nerve. Myasthenic patients are more susceptible to neuromuscular blocking effect of these drugs. Hence, they should be avoided. Hypersensitivity reactions are rare. Occasionally, skin rashes, drug fever, and eosinophilia can occur. Cross-sensitivity between aminoglycosides may also occur. Use of aminoglycosides during pregnancy may cause ototoxicity in fetus. Now let's have some brief discussion of some examples of aminoglycosides. The first is streptomycin. Streptomycin was the first aminoglycoside discovered in 1944. The common properties, mechanism of action and adverse effects have already been discussed. Uses. Streptomycin is one of the first line drug for tuberculosis and is used in combination with other anti-tubercular drugs. The other uses include tularemia, plague and brucellosis. Gentamicin. It is the most commonly used aminoglycoside antibiotic for aerobic gram-negative bacillary infection due to E. coli, Klebsiella, Proteus, Enterobacter, and P. aeruginosa. It is also effective against gram-positive infections, Enterococci, S. viridans, and Staphylococci, but not Mycobacterium tuberculosis. It is available for parenteral and topical administration. Neomycin is highly nephrotoxic, hence it is never used for systemic effect. It is only used for local effect. Neomycin is used topically and orally. Topically, it is used for skin and mucous membranes, for ulcers, wounds and burns. Infection for the eye and external ear, neomycin is used in combination with bacitracin or polymyxin B. Orally, neomycin sulfate is used in combination with erythromycin base for preparation of bowel before abdominal surgery. Neomycin is used in hepatic encephalopathy. Neomycin on oral administration reduces blood ammonia levels by destroying the colonic bacteria. Neomycin is highly toxic, hence it has been replaced by oral lactulose, which is preferred for hepatic encephalopathy. Fremicetin, which is famous for the name soframycin, is also highly nephrotoxic, hence it is not used for systemic administration. Fremicetin is widely used topically for skin, eye and ear infections. Amikacin. Among the aminoglycosides, it has the broadest spectrum of activity. It is resistant to aminoglycoside inactivating enzymes. It is useful for the treatment of nosocomial gram-negative infections and tuberculosis. Tobramycin. All features are similar to those of gentamicin. It is superior to gentamicin against P. aeruginosa, useful in the treatment of serious infection by this organism. Paromomycin. It is an aminoglycoside with activity against protozoans. It can be used in intestinal amoebiasis, giardiasis, vaginal trichomoniasis, visceral leishmaniasis, and hepatic encephalopathy. Netilmycin. It is resistant to aminoglycosides inactivating enzymes, hence effective against most of the gentamicin-resistant bacteria. Now let's discuss the therapeutic uses of aminoglycosides. Among aminoglycosides, gentamicin is the most commonly used because it is cheap and effective against most of the aerobic gram-negative bacilli. Aminoglycosides is used in severe aerobic gram-negative bacilli infection, that is for urinary tract infection, pneumonia, meningitis, osteomyelitis, septicemia, peritonitis, infected burns, all due to Pseudomonas, Klebsiella and E. coli. Gentamicin, tobramycin, amikacin, netilmycin are effective against P. aeruginosa. Amikacin and netilmycin are used for treatment of serious nosocomial infections due to gram-negative bacilli. Aminoglycosides are often used in combination with penicillins and third-generation cephalosporin in these conditions. Aminoglycosides are used in bacterial endocarditis due to S. viridans and Enterococcus. Gentamicin is used in combination with penicillin or vancomycin. Combination broadens the spectrum of activity, produces synergistic effect and decreases emergence of resistance. Combination of penicillin G plus gentamicin is used for S. viridans and combination of ampicillin and gentamicin is used for Enterococcus. Vancomycin plus gentamicin for Enterococcus for the patient who are allergic to beta-lactam antibiotics. And gentamicin and ampicillin combination is used for the prophylaxis of endocarditis in high-risk patients before surgical procedures. Streptomycin, kanamycin and amikacin are used in the treatment of tuberculosis. Aminoglycosides are also used in other gram-negative infections such as plague, brucellosis, and tularemia. In plague, streptomycin or gentamicin is used intramuscularly. In brucellosis, streptomycin, gentamicin is used in combination with doxycycline. And in tularemia, streptomycin or gentamicin is a drug of choice. Fluoroquinolones and tetracyclines are also effective in tularemia. Gentamicin, tobramycin, neomycin, cysomycin, fremicetin, etc. are used topically for gram-negative skin, eye, and ear infections. With this, we conclude our session. Thank you for listening. I hope you understood it. And if you liked it, please share it with your friends and spread knowledge. Thank you.